how to recognize obsessive compulsive behaviors. And I'm going to say OC in the future because saying obsessive compulsive several times is not terribly useful, and I'll stumble on the words. It's important to learn why these behaviors happen. It helps us understand and then try to adjust and adapt to them. And then finally, and importantly, we'll talk about management strategies. I think if we learn these things, we will be better able to deal with our loved ones when this symptom occurs. And that's the primary reason for giving this talk. I'm going to give some definitions now. Now, this may date me. If you don't know this guy, his name was Monk, and he was in a very popular television show a bunch of years ago, which you can still access on Netflix. And he had obsessive compulsive disorder. An obsession is a repetitive or repeating thought or idea, like, and particularly in Mr. Monk's case, germs are everywhere. And a compulsion is a repetitive action. So thought to action is a compulsion, and hand washing as the example. The other things that go along with the disorder is that it's irrational. But, you know, it does have some basis in reality. There are germs everywhere, and it's good to wash your hands. It's just when it gets out of control and uncontrollable that we call it obsessive compulsive. It's important to remember that it's not voluntary. It's not willful. It takes great effort not to do what is obsessing you or is driving you towards the obsessive compulsive behavior. And sometimes you can't stop it without being very, very uncomfortable. It's not willful. And it certainly interferes with social function. It interferes with and puts stress on families, as well as the individual who's suffering from it. So I'm going to kind of talk about the range of behaviors that we can then learn from as it becomes an obsessive compulsive disorder, or what we would call pathology. When does behavior become not logical? Well, you know, it's not so simple. Schedules are important, you know, getting up in time to go to work, to get your kids dressed, to have, schedules are important. Staying on time is important in our busy lives. And hygiene and health routines are very important too. Brushing our teeth, washing our hands, taking our pills. These are routines that are logical but are very routines things and repeating things that we do. What about habits? Particularly, let's talk about some bad habits like smoking. Smoking is not terribly rational. It's bad for you, costs money, doesn't help you. So it's not rational that someone would start smoking. And is it repetitive? It certainly is. And sometimes it becomes very, very hard to control, even if you don't have an obsessive compulsive disorder. So is this, can we call this obsessive behavior? Well, yeah, probably. Now, of course, this habit, there's also a chemical dependency, so it becomes blurred there. So more complicated, and that's why I have all these shades of gray here. Now, we all worry. When does worry become an obsession? When does a particular worry become an obsession? If we can't get it out of our heads, if it keeps going round and round. Another important thing to understand is how insight and level of insight is not completely black and white either. Full insight is when the person knows that the behavior isn't rational or logical, but just can't stop it, can't stop doing it, can't stop thinking it. And then there is the extreme, no insight, where the person is totally unaware that the behavior isn't rational. And this will happen in multiple conditions, including advanced Huntington's. So it's not so black and white. It changes over time in matter of severity and matters of awareness. All OC behaviors have, and I like this concept, cognitive inflexibility. And that's a medical description for the neurologic or brain difficulty in switching, going from one thought or action to another. How flexible are we in doing that? The brain isn't flexible in HD, and it can't easily turn off a thought or action and go to another. It gets stuck, kind of like flexibility in a muscle. Not a very good analogy, but you get stuck in one position, one mental position. Perseveration, I'm throwing that word in there because if you read very much, or you may hear the term in your doctor's office, it's a medical term for OC behaviors that occur in those with limited insight due to cognitive impairment or dementia. Happens in Huntington's, in Parkinson's, in brain injuries, traumatic brain injuries, in Alzheimer's, etc. So it's not unique to Huntington's, and that's a word that's often used in research literature. Getting back to specifically Huntington's, obsessions are more common, or thoughts that recur are more common than our actions. It starts early. It's not severe, can start before motor onset, worsens with stage. I think the experts are pretty much in agreement on that. It is associated with other symptoms or complications of Huntington's, including depression, anxiety, agitation, and occasionally delusions. It's certainly, when we talk about associated with, what we're drawing from is the literature from studies like Enroll HD, and when they ask the behavioral or psychiatric questions, they see which ones tend to go together, and then they pool that data and they use the term associated with. Doesn't mean it causes it, but it's associated with. However, with OC behaviors, it's clear that they do lead to anxiety, agitation, and potentially delusions, which we'll talk about at the end of the talk. It's impactful, certainly, for the person with Huntington's. It's uncomfortable, and it's very uncomfortable for the care partner as well. And I think another fact to be aware of, that there are ways to help manage this symptom or complication of Huntington's. It's important now to the second part of our goal here in terms of recognizing OC behaviors in Huntington's. Well, what are they? One of the earliest ones is difficulty letting go of anger. It takes longer to cool down, get over whatever the conflict was about. Takes longer. And that's a form of mental rigidity, as is difficulty changing schedules or routines can be upsetting to those with Huntington's. It's a mental rigidity, inability to switch from the routine to something new. It's about thinking and talking or worrying about the same thing over and over. It can start as a pleasurable activity. It can start as an activity that was within a routine range earlier in their life, and particularly in the young who know how to operate electronic devices more easily. Electronic games, which may be very useful for mental agility, and is in fact is one of the things to help improve or potentially help improve cognitive function. However, as time goes on, it may be that it becomes very, very hard for an individual to stop a game, and they will play the games, will want to play the games day long, and will be very upset if they are asked to do something else. And this, I have seen this in a couple of younger patients where it becomes an obsession that's uncomfortable. They can't do it. They are very uncomfortable. And they will be agitated if you take it away from them. It can also be ongoing worry about a threat or pain that is no longer severe or may have passed. The threat may have passed, but the thought is still in the head, and there's ongoing worry that they're unable to switch out of. It can feel like, to observers, to caretakers, care partners, like stubbornness, that it's willful. But that is not the case. Some later stage behaviors to recognize, and many of you listening probably have seen this too. It becomes more stressful, certainly, for the individual and for the caretaker. They're more intense, they last longer, and some are potentially injurious too, and this can be socially injurious or physically injurious. The inappropriate verbal outbursts can give an example of an individual who, church-going, quiet individual who, when he developed Huntington's, would start cursing. Never having done this before, would curse at his family, would even curse in church. He could not control these outbursts, had great difficulty controlling them, and though he knew he had some insight into the fact that it was inappropriate, but it was something that he just couldn't stop sometimes. And of course, it was socially embarrassing to both he and his family. So it can be harmful in terms of social interactions, of course. Smoking, which is a habit, can become an obsession in individuals with Huntington's or other cognitively impaired diseases. Toileting, and of course toileting is normal, but it can get out of hand and become something that's repetitive, that someone has to do, or they're very upset not doing. Hypersexuality is another behavior that can fall in this category. Religious zealotry also. Even diet or exercise. An individual who was a competitive athlete who had been very adherent to correct diet and regular exercise, continues this throughout his course of Huntington's to very late stage, and exercise becomes something that he must do, though it harms him in terms of his skin, with abrasions, he will do it when he's not observed, and he will end up injuring himself. The same thing can happen with diet. One becomes obsessed with having health bars, for instance, which then become potentially, well, because of swallowing disorder, can cause him problems that can be very severe, like choking. So those are just a few examples of behaviors. Why do they happen? And I only have one slide on this, and this is much more simplistic than what actually happens, I'm sure. But the concept is there. The action path of an obsessive thought, or what is turned into a compulsive action, goes round and round this feedback loop, with it getting stronger and stronger and stronger, while inhibitory pathways are weakened. The circuit breaker doesn't work, it's stuck. In normal brain function, there is action, and there is action neurons, and then there are other neural paths that inhibit the same activity, and they are balanced. With OC behaviors, they are not. The inhibitory pathways are weakened, and the thought goes round and round. How do you manage this behavior? Well, you try to interrupt that feedback circuit, and I call it throwing in the wrench. There are various strategies for throwing in the wrench that include both behavioral interventions and drug therapy, and we'll go into this in more depth later in the talk. It is changing and adapting environmental triggers for this behavior, changing the carer response, and then drug treatments. As with many things in HD, combinations of behavioral and drug management are often required. OC behaviors are unlikely to occur in isolation. There will probably be depression or anxiety or other symptoms, which will entail treatment of those symptoms as well. So it's not seen in isolation, but to simplify things, we will talk about it as if it is an isolated symptom. First of all, one needs to set realistic goals for this complication of Huntington's. These behaviors are hard to treat, harder than anxiety, harder than depression, harder than psychosis. We have to set realistic goals and realize also that even in the best of circumstances, this complication will not completely go away. We can make it more livable, less distressing, both to the individual with Huntington's and caregivers with interventions. And I'll divide this kind of into 3 stages of management. Now, if you are listening to this and your individual has more severe disease and more severe symptom, then the earlier parts of this will not apply. But overall, it's always good to take care of a complication early. And you can't take care of it early unless you know the symptom, understand it, and recognize it early. And that's what I call the get ready. And that's really preventative therapy. Think of diabetes. If we know a person has diabetes, then if we know what the symptom of low blood sugar is or high blood sugar is, and understand why the symptom is occurring, recognize it early, then we can prevent or at least adapt to the situation earlier. And then getting set are really proactive things, both for the individual with very early disease and for care partners at any stage of disease. Learn about potential behaviors or overstimulation triggers that can make the distress or increase the severity of this symptom, like noise, excessive noise, multiple demands, coming too quickly for the person to switch from one thing to another. Those are overstimulation triggers for individuals with Huntington's that can then lead to agitation or anxiety. Early on, start modifying or simplifying the environment. And by simplifying, I mean giving more time for the person with Huntington's, cutting down on the noise and the stimulation that the person is dealing with. Learn about carer do's and don'ts that will be helpful for this symptom, and these can often be helpful for other symptoms as well. And then be ready to go beyond this behavioral intervention to drug therapy, but when you go to a drug, you don't stop the behavioral interventions. They remain very important. Some do behavioral modifications: simplify, simplify, simplify. Regular schedules that include more time for change. If change is necessary, if something comes up where you have to change a schedule, if possible, give advance warning. So this gives them time to switch without as much distress. Understand, if possible, the trigger or origin of the behavior. You know, does this behavior tend to happen more often when a certain individual is around or a certain situation occurs, and then try to modify those things. Distraction is a very important behavioral management for this symptom at whatever stage, and I call this the behavioral wrench. You throw in a different idea or question which will distract them from the thought that's going round and round. For instance, if I have a patient who will continually go back to the same complaint of pain or another medical problem, and if I will then interrupt with saying something about the grandchildren or something about family, something about good weather, that will help lessen and not make the round and round continuous. Setting limits on the behavior can be helpful. Another patient who was in an adult family home who had a cell phone and called her husband every hour, interfering with his work. And if he didn't answer, she would be very upset. So we set limits, and we said, and took her phone and said, your husband will be available twice a day. And you can call, we'll give you your phone, and you can call at this time, and you can call at another time. And that did work. Now, will it work in everyone? No, you may have to set a different kind of limit. But setting limits is possible even when the disease is quite advanced. A calm and non-judgmental response is very important. becoming angry or upset with the behavior will escalate it to something more challenging like agitation. I think it's also important to validate the anxiety associated with the behavior, not the behavior itself, but if there is anxiety, you know, I get anxious if I don't talk to my husband, I get anxious if I don't play my game, validating the anxiety, showing some understanding of why the behavior is happening, why it's causing them anxiety. You don't validate the behavior, but the anxiety associated with it. Always, when these are occurring, back off, if possible, and allow time and space for cool down. Remember, it's hard for individuals with Huntington's to switch from one thing to another. So longer time and space for cooling down is very important. So back off, even if you have to go into a different room. The do not behaviors of management. Of course, you don't intervene if the repetitive behavior is not causing stress. It may be something that is soothing. That's okay. If the individual has a teddy bear and wants the teddy bear with them, this may be an obsessive behavior, but it's soothing. So not everything that's repetitive needs to be addressed. Do not try to rationalize or convince individuals who are having an obsessive behavior that this is inappropriate. You do not try to tell them that something that they have in their head is not true. In very early disease with obsessive compulsive behaviors, I think that the symptom can be revisited and the individual with Huntington's can behaviorally manage some of this themselves. If they are aware that it takes them longer to cool down and it's harder for them to cool down, then they will ask them to leave the situation. Ask them to count to 3 or some other kind of modification to make them aware that they need to cool down and that there are some things that they can do for themselves. Don't respond to this symptom with irritation or anger or force, because this will escalate to more difficult behaviors, agitation, even aggression. Now on to the drugs. There are drug treatments, and also remember that keep your expectations reasonable. This is not a symptom that we can make go away with any management, whether behavioral or with drugs. We can make this complication more livable, less distressing for individuals with Huntington's and care partners. The first drug of choice for all obsessive compulsive disorders and behaviors is the SSRI, the serotonin reuptake inhibitor. The antidepressants, like the most common ones prescribed by Huntington's doctors, are citalopram or Celexa, sertraline or Zoloft, and paroxetine or Paxil. Now there are others too. I only list these 3 because of limited space, but there are others that can be used as well. Also used for obsessive compulsive complications are the serotonin norepinephrine reuptake inhibitors. And the norepinephrine actually should be in front of the serotonin there. Both terminologies are actually acceptable. But I like to have the in first because it reminds me that it's not just serotonin that's being affected, but norepinephrine as well. And the drugs that I'm talking about here are venlafaxine or Effexor, misspelled there, and duloxetine or Cymbalta. I have that in bold letters because that is the SNRI that I prefer because of fewer reactions or interactions with other drugs. Also to remember is that it takes more time and higher dosing than that needed for depression or anxiety. It takes longer for this symptom to respond than depression or anxiety. So don't stop these drugs too soon. And when I say it takes more time, it may take a month or two. And it will take certainly that long or more to reach the best dosage for treating this symptom. Another drug I want to talk about is something called clomipramine, which is an old drug. The other word for that is anafranil is the brand name. This drug has both SSRI and tricyclic drug actions. So again, we have the serotonin action plus a tricyclic action. Amitriptyline and nortriptyline are drugs that are tricyclics. These are old drugs that Elavil is another word for amitriptyline. These are older drugs. They can be used in Huntington's as well. They have more side effects, so they are used less frequently than are the SSRIs. And so they tend to be reserved for more severe situations or when these other drugs aren't effective or aren't tolerated. There are side effects that these drugs have. Then this is a drug certainly to go to with realizing that it may have some more complications associated with it. Clomipramine should not be used with another SSRI or NSRI drug because then you're double dosing, and then double dosing gives you more side effects. I have used this drug carefully and have found that it works well it often works well in those who have not responded to the SSRI. In the algorithm for treatment of HD, obsession and compulsions of pharmacologic treatment that Dr. Karen Anderson is the lead author on. She's quite the expert also in obsessive compulsive disorder problems in Huntington's. The survey showed that those physicians who used this drug thought it worked well, but the majority of neurologists have not used this drug. So, and because it has more side effects, it may not be used as effectively as it perhaps could be. Now the why. Why do serotonergic, and I use that word to encompass both the SSRIs, the NSRIs, and clomipramine. And that's because studies show that brain scans of the abnormal circuits improve after people are on these drugs. It's the pharmacologic wrench, throwing the wrench in for management of this complication. A word about antipsychotics. Antipsychotics are not the drug of choice for obsessional compulsive behaviors. I'm going to say that again. Antipsychotics are not helpful for these behaviors. They are helpful for other symptoms that may accompany OC behaviors, for instance, agitation, which can be associated with OC behaviors. So it's not wrong to use them with this symptom, but they aren't the first drug of choice. Now, the title of this presentation also had pain in it. Can pain become an obsession, an obsessive disorder in Huntington's? can it look like a delusion? Though it's not specifically reported in Huntington's, it is described in other OC disorders. And I believe that I've seen something similar in HD. A gentleman who complained of pain in his feet, and for many years, various evaluations that had been really quite complete didn't find an etiology for this. He was tried on various drugs to treat neuropathy or other painful conditions. He was also given various pain medications without benefit. The pain became severe enough that he would not walk and would go into a wheelchair, and he got very depressed. He's in a wheelchair, he's having pain, he's thinking about pain all the time. You cannot have a conversation with him without his bringing up the pain. And he was on an antipsychotic when I met him later in his disease. We discussed this, and there had been a question on my part whether this was a delusion that was associated not so much with psychosis, but with being obsessed about the pain, going round and round. Now, he did not respond to antipsychotics, but he did respond to an SSRI. He no longer talked about the pain all the time. He still had pain, complained of pain, but it was not, he could do other things. He could play games with other people. He was much more interactive with his family, and would only bring up that there was still pain if you ask him. So he was no longer obsessing on it, so it was less distressing for him. So I actually believe that this was a delusion associated with an obsessive behavior that started with something real. You know, as many of these behaviors do. They start with something that is real that then becomes irrational. The behavior becomes irrational regarding the real thing, the thing that happened, can become delusional. So I think that's an important point to make, because often, I'm not going to say often, but I'm going to say that it may be potentially useful to try an SSRI. And thank you very much for listening. Hope I haven't been too quick and gone through things and made them too complicated. I welcome any questions.
Our first question, does it help to do breathing techniques with the patient?
A relaxing distraction, and it is very effective.
So if I remind myself to breathe in through your nose, out through your mouth, do that a few times, then I can manage what it is that I have to manage and not be so stressed about that.
Indeed.
Yeah. We talked about preventative measures. Can you give us some ideas of how to prevent some of the obsessive compulsive behaviors? Can we prevent obsessive compulsive behaviors?
I don't think that one can prevent them. One can lessen the discomfort. When I say preventative, that doesn't mean that there are techniques that one can use so your individual with Huntington's will never have this symptom. This complication will happen. It's recognizing it, being able to know what the symptom is before it occurs so it can be recognized and adapted to early on, before pathways get thicker and thicker and thicker in that roundabout action pathway. You can't prevent the complication. When I say preventative of the intensity of it is actually the much better concept. Simplifying the environment. These are very helpful for other symptoms with Huntington's too. Agitation, you simplify the environment. You do not make as many demands. You give longer time for people to eat, longer time for people to get dressed, so they will not be stressed. They cannot do things quickly. So staying on someone else's schedule is just not going to happen. So adapting to those schedules will make it much easier for both caretaker and for the individual with Huntington's. Now, sometimes you can't do that. You know, sometimes things come up where you can't. You have to be, there has to be some flexibility, and remember that person who couldn't bend. It's harder for people to understand that it's harder for people to adjust to a change, to bend, to switch.
Is it okay to tell the HD person that their behavior is not appropriate?
I think it's an error always to blame the victim. Error is too strong of a word, but to think of it in different terms. The agitation is usually a call for help. Some need is not being met. Now, I don't know this individual situation and can't be specific, of course, nor would I without being this individual's physician. Look for things that are making this person agitated. Is he or she uncomfortable in any way? Is there pain? Is there a urinary tract infection? Is there constipation? Is there hunger?
We have a guest with a situation. Her father is in a care home and he's not cooperating with the staff about changing his clothing. What should she do?
What I have found helpful, I'm not for sure this will work, is that you make up a schedule for when he changes his clothes. If there are stains on his shirt for part of the day, that's not terribly important. It's less important than having him become agitated. Getting a specific routine in place where he can know about it's happening in advance, can plan for it, can switch his head to be able to deal with it. Sometimes making a specific schedule will be helpful. It may not in your father's situation, but I would try that first.
Same guest, another situation. Her father is choking and banging on the table. He's sneaking food. The home is telling him that he can't do that. He doesn't want to go to another facility. What should she do?
Sneaking an apple also suggests that he's still hungry. Having the home be aware that an individual with Huntington's may not know that they're eating too quickly, may not know that they're gulping, to be reminded. So a person who doesn't necessarily need to be fed, but can, if there is someone sitting with him, for instance, reminding him to slow down.
Another situation. The home staff is trying to help her father during feeding time, and he's telling them to stop being so bossy.
Well, I probably at this point, again, I don't know your father or what medications he is on. I mean, he's unhappy because he can't do things the way he used to do them. And that makes for unhappiness and for agitated behavior. An understanding of that and validation of that, I think is important. That, you know, we realize, Dad, that this is becoming hard for you. And this is hard for you. This is emotionally hard. Sometimes validation will help, and then let folks help you, and you will be able to do this longer. You need to choose your rationalization, I guess. With a carrot instead of a prod, you not choke. This will help you live longer, or potentially keep your function. The longer that you can swallow without choking, the longer you'll have success. You know, the more well you will be. I have found, you know, find a way to offer the carrot. That, you know, there are lots of things that you like about this place. These people really care about you. They want to help. They want to care for you. They care about you. It's not just that they want to do this for you or do that for you. They care about you. The other, and sometimes it's hard to find that place. And it may be that there will be need for more medication to help calm his agitation. It sounds like he gets agitated, you know, banging his, this is agitation. And, you know, what I would do in this situation is observe him swallowing. One other thing that is, at least has occurred with my experience, is that when an individual chokes, then they are afraid of choking with every bite. I would limit the distractions at his table. Does he eat with other individuals? Any calming influence while he eats. You know, he's taking his Ensure. Maybe you need to concentrate on those things that he takes well, that he enjoys. Make an apple shake instead of pureed applesauce. Find a way, and thick, you know, of the appropriate thickness, and that may work. So take what works, the Ensure, ever how they're doing it, and work around that.
Thank you for your questions about this. It's really important to talk about that, because sometimes, you know, our loved ones are in a different place and we can't control their environment. So it's really important to be able to know the signs, and like Dr. Goodman says, you know, there's reason for the behaviors, I think, typically. So thank you, Dr. Goodman. That's really good information. A couple more questions real quick, and then we'll wrap it up here. Gosh, it's almost been an hour already. We were talking about distractions. How do we best distract? I mean, do you have some methods of distraction so that we can kind of redirect our loved one when they're stuck in a loop, so to speak?
What is it that gives this individual pleasure? Does his family, talking about his family, does talking about football, unless football is the obsession. So you know, you don't feed into the obsession, but let's say there's something else going on, and then but they like football, or they like some other show, TV show, music, something that's pleasurable to them, that has been pleasurable to them, then intervene with that wrench. Now, I call it a wrench, and you know, we all, when we worry too much, we try to distract ourselves or relax ourselves. The breathing, for instance, is both a distraction, because you're concentrating on breathing, so you're pushing out that other stuff that's in that other noise that's in your head, or that's what you're trying to do. And that's a behavioral kind of cognitive therapy that we do with ourselves. So extending that to a little further, the wrench has to be a little more obvious, I guess. You know, if it becomes there's some thought is going round and round, then find something that they gave them pleasure, gives them pleasure, or gave them pleasure, and talk about that. Bring that up, and see if that helps.
Trying to switch them around a little bit.
Well,
A little distraction. Let's see. Okay, one more question. So we talked about the SSRIs and the SRNAIs. SNAIs, what are they?
NS or SNRI, either one.
Too many N's.
Two S's, there's an N.
When is it appropriate to then try the antipsychotic medications?
I would not use an antipsychotic for this symptom at all.
Okay.
I would go to clomipramine next.
Okay.
And I have often, not often, but in the more severe individuals with more advanced disease that it's causing agitation in. Now, an antipsychotic, you know, calms the person. So does this, or, you know, knocks them out a little bit. It helps the anxiety, the agitation. It helps those other symptoms that go along with the disturbance, mental disturbance that the obsessive behavior causes. So it's not that they shouldn't be used, but realize that you're using them for other behaviors. If the primary disorder or the thing that's causing the most problem is really an obsessive compulsive one, an antipsychotic's not going to help that at all. In my experience, at least, and in my opinion, I would go to the clomipramine, using it carefully. It has more side effects like postural hypotension, so changing directions or changing a position, there will be more lightheadedness. So might there be more falls? Yes, unless there is care taken. Realize that might be a situation, and you know, anticipate it. Up on my website, I have updated a little bit an article on obsessive compulsive things at HDDrugworks.org that contains some of the things that are in this talk.
I'm typing that into the chat right now, HDDrugworks.org, so that y'all can click on her website. Dr. Goodman, thank you so much for taking this valuable time to speak to our community, and we so appreciate you more than you know. So
all of you, for heaven's sakes. It's mutual.
Thank you. I don't have any more questions, so I think we'll wrap it up. And thank you all for joining us. And again, Dr. Goodman, thank you. PMD Alliance, we love you. And we'll see you next month with our every third Tuesday Lunch with Docs HD. And I'll be sending out notices. So please visit our websites, hdrugworks.org and HDSCN.org and PMDalliance.org to follow.